Buon pomeriggio a tutti, cominciamo questa sessione. It's a great pleasure to me to introduce Professor Gerald Criner from Philadelphia, USA. He is the main investigator of this COPD gene project, which has produced a lot of data recently in the literature. So we are really interested in knowing new data about this project. Please.
Thank you, Mr. Chairman, and thank you, Leo, for inviting me here. And I spent about 6 or so hours today with the young trainees in pulmonary from Modena and the other institutions nearby, and looks like we're going to be in a good place in the future. They are bright, they're intelligent, and they did an outstanding job. And it's a testament to all of you who are training them to have such good, intelligent, and industrious trainees. So what I was asked to speak about today is the COPD gene product, which is a project, which is a US-based consortium. And it's devoted towards trying to advance our knowledge in patients with COPD. This is my disclosures for monies received for grants and consultation. So what is COPD gene? COPD gene is really a study of people that are smoke exposed. The plans for this at the inception was to take individuals in a cross-sectional study, approximately 10,000 individuals, and study them from a genomic, clinical phenotyping, as well as a radiographic standpoint. So it's over 10,000 patients. This is a large cohort of smokers, and we took polar opposites in terms of genetic makeup by taking non-Hispanic Caucasians and also African Americans. So if there is genetic differences that are found in COPD, we'll be able to highlight that. So we have this kind of tripartite sort of analysis with genomics, clinical data for clinical phenotyping, as well as extensive chest CT characterization. This is the components of COPD gene. I'm the PI of one of the clinical centers in Philadelphia. We have 18 centers across the United States to enroll these 10,000 patients, and we have certain cores, both for imaging, genomic processing. We have a biorepository of proteomic material at Johns Hopkins, and we do have a candidate genotyping core at the Chandling Center at Brigham and Women's, and the data coordinating center is at National Jewish. The overall PIs of the entire project are James Crapo from University of Colorado and National Jewish in Denver, and Ed Silverman, who's at Brigham and Women's Hospital in Boston. So let me just give you some details of what we're studying in this project. These are some of the clinical study variables. The obvious things that we collect would be the things that you would logically expect. Demographics in terms of the items that are listed here. Physical exam, we do a history and physical and check their height, weight, and pulse oximetry. There's a variety of different questionnaires that are disease-specific, such as the ATS respiratory questionnaire, SGRQ for quality of life, and depression and anxiety index with HADS. And then we look at some clinical variables, such as their dyspnea by MRC, their exacerbation history, and comorbidities, for which has some important implications, as I'll describe to you later. Then we use the integrative index of the BODE to characterize our subjects, do pre and post bronchodilator spirometry, 6-minute walk, and then chest CT imaging. One of the unique features of this study is that all patients get N-inspiratory and N-expiratory imaging that's allowed us to explore gas trapping and be able to look at patients who have significant airways obstruction but don't have emphysema, which is hypothesis generating for some new projects. The genotypic analysis is shown here. There will be a complete genome-wide SNP genotyping and data cleaning that's done in the complete cohort. And then GWAS of COPD affection status and a broad range of COPD-related phenotypes will occur later on. And we expect to do complete exome sequencing analysis of COPD gene subjects in probably about 10 to 15% of the cohort. Although this data isn't available as yet, there's been some preliminary data generated by using these QQ plot analysis of both the control non-Hispanic whites and African Americans, that there's two locus that have found that seem to predispose to COPD. One is a novel finding on susceptibility locus at 4q22.1 in the FAM13A locus chromosome, and the other one is on chromosome 19q13 locus. So we expect and hope to find more genetic association and marry them with clinical and radiographic phenotypes that we can find a genetic predisposition to COPD. This line item just really shows the breadth of the study overall. Currently, we're in the follow-up. So we're, at our center, we enrolled 1,200 of the 10,000. We're seeing about 5 patients a day just for COPD gene to characterize them, and we have to keep on this schedule for the 5-year follow-up. But in the total study, we enrolled 10,322 subjects. About 6,800 of these were white, and approximately 3,300 of these were African American. It's about an equal distribution of males and females throughout the study, as you can see. And then the study, as I said, was smoke exposed. So approximately 40% of the cohort, over 4,000 subjects, didn't have physiologic or clinical data that would describe them as having COPD, but definitely were smoke exposed. We have all the information on them. And then approximately 4,000 of these patients had GOLD 1 through 4 disease, with a majority of these being GOLD 2 and 3. You can see here there's a GOLD U classification here, which is basically they could not be defined by GOLD in 1,200 subjects, and that ends up being a new phenotype that we developed, clinical phenotype that we developed that will describe that to you a little in a subsequent slide. And we also had a control group of people that were not smoke exposed. They were 108 individuals, both Caucasian predominantly, a few African American, and we hope to expand that to about 250 additional people in COPD gene phase 2. So this is the distribution of the subjects if you take them by the degree of airflow obstruction overall. This is the FEV1% line here in blue that defines by 80%, and this is the FEV1 FVC ratio here that defines by 70%. You can see below this line you have GOLD 1 with a higher FEV1, and then GOLD 2 to 4 with an FEV1 less than 80% of predicted and a ratio less than 70%. You can see the scatter plot of the normal individuals here. And this ended up being somewhat of a surprise to us, but the group that we characterize as GOLD U, the group that could not be defined by GOLD, those who had an FEV1 FVC ratio greater than 70%, but an FEV1 less than 80%. And what we found by those, in these individuals, and reported this in a Blue Journal several years ago, that these individuals end up having more of a metabolic profile. 9% of the smokers overall in COPD gene. This is a cross-sectional study. It wasn't patients that just were coming into clinics. We put ads in newspapers and on the media for people that met the criteria by demographics and by smoke exposure to come into the study. So it was a real cross-sectional analysis of the population. But these individuals had increased BMI. They had a disproportionately reduced total lung capacity measured by volumetric CT. They had increased wall thickness and less emphysema on chest CT, and they had decreased gas trapping and less bronchodilator responsiveness than people that had met the GOLD criteria for COPD. And they overall, because they were more overweight, had more of a metabolic predilection, had an increased prevalence of diabetes. We also clinically described early on a group of individuals that developed COPD at a younger age. These were predominantly women. As you can see here, between the age of 40 and 50, it was almost 2 to 3 times greater, and reconfirms the Boston early onset COPD trial that again showed that females were more likely to develop COPD earlier than males. And when we looked at those factors that went into that population a little bit more closely, besides being women, they are more likely to be African American than being Caucasian. They overall had more symptoms and more airflow obstruction with a disproportionate less degree of smoke exposure. They were more likely to have a mother who smoked, and especially smoked while the child was in utero, and a mother that was more likely to have the clinical diagnosis of COPD. And overall, when we looked at their CT scans, they more likely had obstruction from airways disease more than they had from emphysema. We also found that approximately 11.5% of the patients that came into COPD-G had a co-diagnosis of asthma in this group by historical criteria overall. And when we looked at those patients who had history of overlap with COPD and asthma, they were more likely to have exacerbation, and more importantly, more likely to have severe exacerbations that required ER visits or hospitalization. And when we look at those individuals, the ones who had the co-diagnosis of asthma and COPD, they were more likely to be blacks, they were more likely to be males, again, they were more likely to be younger, and they had less smoke exposure, suggesting that something in the environment or something genetically predisposed these individuals to have a greater and a somewhat different symptom burden at a younger age. Well, as everyone knows in this room, COPD isn't radiographically one disease. And these two slices identify this concept that patients with almost comparable FEV1s percent are predicted. And the patient here to the left in the up cross-sectional image and then the mid-lung image has very little emphysema and has more airway wall thickness, in contrast to this patient on the right, who, although similarly obstructed, has significant upper lobe predominant emphysema and less airway wall disease. So although these patients spirometrically present the same, radiographically they are structurally very different. So what we're trying to do in this study is comprehensively characterize the radiographic pattern of emphysema and do that by quantitative and qualitative analysis. From a quantitative standpoint, we're looking at emphysema in terms of its extent and distribution, and we're looking at the airway wall in terms of its diameter and its bronchial wall or airway wall thickness. And then, as I mentioned on the expiratory films, we have the ability to look for gas trapping and compare that to regions of the lung that have emphysema or more airway wall thickness that may go into their pattern of gas trapping that's found. From a visual or qualitative avenue, we're looking at the pattern, extent, and distribution also of emphysema. We're looking at the airway wall to see visually if we can detect if it's thickened or if it's dilated. And then in small airways, we're looking for the presence of central lobular nodules and gas trapping, as I mentioned. And then a fourth avenue that I'll describe a little bit tomorrow when I talk about phenotypes in COPD, we described a cohort, about 8% of those who came into COPD gene who have an associated interstitial lung abnormality, in addition to having evidence of gas trapping or emphysema. From definable subtypes, these are what we pre-specified going into the project. That for emphysema, we'd look at the different qualitative patterns of emphysema as shown here. We'd also look at the region in the upper, lower, or diffuse patterns, similar to what we did with the National Emphysema Treatment Trial or with NET. And then we would have a scoring of the severity of the emphysematous destruction of the lung. From a small airway standpoint, we would look for ground glass opacities and central lobular nodules and gas trapping, bronchial wall thickening, and then some other abnormalities, such as the structural presence of bronchiectasis, bronchial outpouching, saber-toothed trachea, and tracheobronchial malacia. And to determine whether we actually can make this, early on we had a workshop where we had about 30 physicians, half of them being radiologists from around the world, same with pulmonologists, and we all scored the same CT scans, about 500 images, to see if we could have what kind of kappa value or agreement we would have in coming up with these qualitative definitions. And we wrote a paper that's in the Fleschner Society that came out about 2 years ago, looking at the levels of agreement with these various indices. This is what we use by VITA and Slicer imaging data. These are two software programs that we have that we apply to the study. We do a cytoskeleton of the airway reconstruction. Some of these are easy to define. In other avenues, we have to reconstruct the airway depending on the image quality. But we have an imaging core that qualitatively assesses the image to make sure anything that goes into the data set, the image has been conducted reliably with good quality, and the airway and lung parenchyma can be scored. We also have each of our scans that we use They've all scanned with phantom imaging, so there's standardization across the 18 centers and across the 18 center scanners that the patients are having the same images displayed in the same manner. And for the follow-up part of COPD gene, we're asking that all of the subjects be scanned on the same scanner that they were in the original cohort. In any event, this is what we do in the images on the longitudinal aspects of the airway, and then cross-sectional dimensions are done at various segments throughout the entire tracheobronchial tree. And this is what we look at on the longitudinal aspect. We look at wall thickness at the segmental and subsegmental areas. We look at internal luminal diameter from the cross points shown here. And then we look at the wall area percent by adding up or measuring the area of the airway wall. And then we do the same thing in a cross-sectional area at the different segments of the airway wall. This is some examples of what we're able to define when we look at this on wall area percent by airway level and gold stage of COPD from the trachea down to the fifth generation of the airway down to the sub-subsegmental level. And if you look at this, the gold stages goes from gold 0, which is dash line, up to green, which is gold 2, and to red, which is gold 4. And as you can see, in an ascending stage of severity as reflected by gold disease, that in patients with gold grade 4 compared to the lower levels of gold have more airway wall thickness across the spectrum of the tracheobronchial tree. We're not so sure of how confident we are in the subsegmental area at the 5th or 6th generation, but we believe at the segmental and subsegmental area we have pretty good precision in this ability to estimate airway wall thickness. If we look at some physiologic characterization of what we found with COPD gene in terms of quantitative indices of emphysema and compare that to spirometry, we reported this. Schroeder was the first author in AJR about 4 months ago, that we have fairly good agreement between lung attenuation area less than 856 with FEV1%. As the attenuation area becomes greater, you can see that there's an indirect relationship that the FEV1 is lower. And we see the same thing for the FEV1 FVC percent. When we look at airway wall thickness, we again find significant levels for the same relationship at the 5th generation of the airway, but it's not as robust in terms of the degree of airways obstruction as we find with the quantitative indices for emphysema, or looking at airway luminal areas at the more proximal airway lumen. One of the things what the expiratory scans have told us is about the extent of gas trapping and how that relates to the presence or absence of emphysema. And in this slide here, in the first 2,500 people in gold 2 to 3 COPD that looks at percent of gas trapping, again, measured by the expiratory CAT scan at Hounsfield units that are less than 856, we find it's a fairly good relationship with emphysema in about 60% of the cohort, but 25% of the cohort can have extensive gas trapping that ranges anywhere from 20% up into one individual to about 85% and has less than 5% emphysema, the threshold of which we think is significant or not. You can also see here that there's about 1% of the individuals that have negligible gas trapping but still have emphysema. So what we see in this study is that patients tend to have gas trapping that relates to the degree of emphysema, but there's a substantial minority of patients, about 25%, who can have extensive gas trapping and have little to no emphysema that's present. It's even more striking when we look at smokers without COPD, those who smoked and don't have any symptoms or airways obstruction, and we look at gas trapping or emphysema, and people that are basically asymptomatic in terms of how we diagnose the disease currently. And we can find that approximately 26% of this group of individuals can have significant gas trapping, and approximately 6% of these individuals can have significant emphysema overall. So we have about 40% of patients who don't have a diagnosis yet of COPD who have structural evidence of emphysema or gas trapping because of prior smoke exposure. Now, is this going to lead us to define the disease a little bit differently later on? We don't know as yet, but this gives some credence to the notion that structural imaging by CT scan of the chest is a sensitive way to maybe detect earlier disease or the extent of the disease. There might be some other new radiographic tools that we could use to further describe our patient groups and their prognosis over time. This is a group of patients in COPD gene. It was about 11 individuals at University of Michigan, where they did parametric response mapping. This is a group of neuroradiologists who were using this to look at brain tumors and then applied this to patients who were in COPD gene who were smoke exposed. And what they do in this case is by voxel, they co-register the inspiratory and expiratory images. So they can take each voxel and they can look at that segment of lung and see if it's gas trap due to emphysema or gas trap without emphysema, and then be able to capture and digitize the information and then do these color-coded maps where the green is normal lung, the yellow would be patients that are gas trapped but don't have emphysema, and then those who are gas trapped due to emphysema are shown in the red area. So just to illustrate this, this is on the y-axis, this is Huntsville units at inspiration, looking here from -500 to -1,000, and then similarly on expiration, -500 to -1,000. And as you can see in this normal individual who didn't have much in the way of gas trapping, most of their voxels were shown here in the green, in this region where their Huntsville units were predominantly less than 850 on inspiration and expiration. This is an individual with COPD, and as you can see in this case, this individual has predominant DIR shadow in the area of bordering on -950 and dead center on N inspiration, and on N expiration had some units here that were gas trapped but didn't have emphysema, shown in this region overall. So if you look at patients overall, you can color code him into this image. This is a patient here with a FEV1 of 800 mLs, done at month 0. This is the degree of normal lung that they had. This is the degree of gas trap lung that they had, and this is the degree of emphysema. And if you look in aggregate, this is what they looked at time 0. Then 11 months later on, you can see that the extent of normal green tissue that the patient had over time on further imaging was less, that there was less in the area of gas trapping, but there was more in the area of emphysema. So over this period of time, at least by this image analysis, this patient had a progression of obstructive lung disease with more emphysema over that period of time. So this may allow us the opportunity to look at patients non-invasively, to look at their progression and the type of progression of disease over time. Well, one of the things that this has to do is be histologically confirmed. And now we're working with University of Michigan, Temple, we're working with University of Michigan with Jim Hogg in British Vancouver. And what we're doing is at the time of transplantation, we take one of the lungs that are explanted from patients with COPD, we inflate that lung to total lung capacity, and then at residual volume ex vivo in radiographic imaging, so then we can co-register those images. Then we inflate that lung back to total lung capacity, and we freeze it with a liquid nitrogen vapor at -80, and then we saw it on bandsaw, and then we core it at the areas of interest, and then send them to Jim Hogg, who does micro CT. So we can then look at the images both on CT that's enlarged, as you can see here, these small areas of emphysema, and then on micro CT we can define a few. But for the most part, this is a normal lung slice that we did to show that we can do this, and we just got funded by the NIH to do this in a cohort of 50 individuals. So hopefully we'll be able to histologically confirm this imaging modality that potentially has great promise to further advance our knowledge of COPD and its progression. So there are some things right now from qualitative inspection of the CT that you can get that allows us to know that, again, that all COPD and even all emphysema is not the same. So what we recently did in this paper's in review, we presented this a year and a half ago at the ATS, is we looked at the clinical characteristics of COPD based on the qualitative pattern on high-resolution CT. And these are examples of a patient who has central lobular emphysema, paraseptal emphysema or pleural-based emphysema, one who has panlobular emphysema, and then one who has mixed emphysema, central lobular, paraseptal, and panlobular disease. And what we wanted to do was find out how does this qualitative pattern relate to the degree of obstruction, gender, and race, and clinical characteristics or clinical symptoms. And what we found here is that as I mentioned before, even in patients that have no symptoms or diagnosis of COPD, we can find emphysema present in about 25 to 30% of that cohort. And when we look at that group of individuals, they're more likely to have paraseptal emphysema than any of the other groups of patients who have more advanced GOLD grades. In fact, as you look across the GOLD stages, it's very unlikely that you'll have no emphysema as you go to GOLD grade 4. Less than 5% of the patients had no evidence of any significant emphysema in that group. But as you go across the GOLD grades, you find that the degree of paraseptal emphysema is less, the degree of central lobular and mixed emphysema becomes greater, and over the period of time, panlobular emphysema that's shown here in the yellow becomes greater in GOLD's grade 3 and 4. So besides the percent of emphysema that's present, the type of emphysema seems to matter based on the advancement of the disease by degree of airways obstruction. If we look at males and females, the degree of emphysema appears to be the same in those groups, but again, the pattern is different. That the amount of women who had paraseptal emphysema was about half the percentage of what it was in males, but they were more likely to have central lobular emphysema in the female group gender than it did in the corresponding male group. And when we look again across the races, this is the fourth time in 4 different studies we've demonstrated this, so I think it's a pretty reproducible finding that overall African Americans, despite comparable degrees of airways obstruction, have less emphysema and have more airways obstruction contributing to their airflow obstruction than Caucasians do. And they also had more paraseptal emphysema overall. So there's different features that we find in a qualitative pattern of emphysema that's based on severity of airflow obstruction, based on gender, and based on race. Well, one of the things that we had in COPD gene, we had the opportunity to look at exacerbations and be able to find and corroborate what was found in an ECLIPSE study or refute it, to see if what factors go into the development of more frequent or more severe exacerbations. And similar to the ECLIPSE study, we found that as patients become more obstructed, that the numbers of patients who have exacerbation goes up extensively. If you look at GOLD grade 4, more than half of that patient group has exacerbation, and over a third of that group has frequent exacerbations, more than 2 per year. And as you can see in GOLD grade 3 and 4, exacerbations are a common and a severe occurrence that occurs in those patients groups. When we looked at COPD gene, and this is looking at 4,400 patients across GOLD grades 1 to 4 in COPD gene, we found similar findings to what Hurst and colleagues found in the ECLIPSE study. So we believe that we've been able to confirm that study in a replicate cohort, that approximately 46% of those patients who are frequent exacerbators and follow up to 3 years after that time tend to be frequent exacerbators, and those who tend to be non-exacerbators tend to predominate and be non-exacerbators in follow-up too. So there's fairly good sensitivity and specificity for those 2 phenotypes. If you look at the infrequent group, they tend to switch into one group or the other one, but the same factors that define who the frequent group are tend to apply in a group that are classified as the infrequent group by ECLIPSE, and by what we used in this study was the same definition, which are these factors. That people that are more likely to exacerbate are more likely to be Caucasians, they're more likely to be women, they're more likely to prescribe oxygen therapy, they most likely have stopped smoking, not so much that we think nicotine has a protective effect, but they become more symptomatic and stop smoking as a result of that. They end up having more emphysema, more burdened by the disease by SGRQ, and then having this clinical profile of chronic bronchitis, asthma, GERD, and wheezing. When we look at severe exacerbations that cause hospitalization or ER visits, again, we find similar factors that predispose patients to have that. The differences is they tend to be older subjects, they tend to be on home oxygen therapy, and they tend to have a lower 6-minute walk test. We also find that of all the factors that predict exacerbation, the highest predictive value is found with severe exacerbation history. If that patient has not had that, they're very unlikely to have that in future follow-up. One of the things that's, I think, a freebie, all you have to do is take a patient's history, is the importance of chronic bronchitis, predisposing patients to frequent and severe exacerbations. This is data from COPD gene on the first 3,500 patients that we reported in chest, that we found that if you had an exacerbation, history of chronic bronchitis based on phlegm production that was more than 3 months out of the year for 2 consecutive years, your exacerbation likelihood was double compared to those who did not have that history. And then your likelihood of having an exacerbation that caused hospitalization was about 26% greater. So a clinical history of chronic bronchitis ends up being very valuable in targeting a patient group who's more likely to exacerbate in the future, even when you adjust that for smoking history, age, race, and gender. Seems to be a signal that goes through that. The other thing that was shown from COPD gene, we can use the radiographic characterization of emphysema and airway wall thickness to help to prevent or help to predict exacerbation history. This is looking at the annual number of COPD exacerbations on the y-axis, and then on the left x-axis, looking at the percent of emphysema, and on the right x-axis, looking at segmental wall thickness. And as you can see here, as you go up with emphysema greater than 35% of the lung, you can see your exacerbation rate goes up to about 1.25. And here as your airway wall thickness goes above 1.75, your incidence of exacerbation goes up to about, again, 1.3. You would assume that if you went here where patients had more airway wall thickness and more emphysema, that this would be the highest ratio, but there wasn't enough individuals who met this criteria to make this statistically significant in that group. So that's why we believe this did not show this trend here being the highest point, but actually the emphysema and airway wall independently have predictive value. We've also reported recently on vascular changes that can be found on the CT scan and used that to report exacerbation frequency. This is data by Mike Wells and Mark Drainsfield, who analyzed this for COPD gene. And what they did in this analysis, they took about 2,500 scans from COPD gene, and they used a replicate cohort from the Eclipse, which was 3,000. So in over 5,000 patients, they looked at the diameter of the pulmonary artery trunk and related that to the cross-sectional diameter of the aorta. And if that was greater than 1, they found that there was a significant increase in exacerbation frequency, but also severe exacerbation that predisposed the patient to hospitalization. And they found that at baseline here shown in the whiter blue, but then when they followed these patients in a longitudinal analysis by telephony, a telephone that was call system that looked at subjects up to 3 years after they enrolled in a study, they found they were able to duplicate that in the same cohort. So they basically replicated this in 2 populations, and then they longitudinally followed the cohort over a period of time and showed similar results. So this is what we're doing in COPD gene phase 2. We just received an NIH award for renewal of this for additional 5 years. Every patient of the 10,000 we're inviting to come back. We hope to get at least 80% of that cohort back, and we hope to get about 94% or greater of at least knowing the vital status on all these patients, whether they died or they're infirmed or in a hospital. We will collect the same data that we collected in COPD gene 1. We'll collect the clinical data, radiographic measures that I've described, physiologic measures, as well as the diffusion capacity, which we didn't measure in COPD gene 1. We will do that in COPD gene 2, and we've just started this right now, as I've told you. So in summary, I think that COPD gene has a wealth of data that characterize distinct patient phenotypes. It allows us to use clinical, physiologic, and radiographic imaging, and then go across the board and integrate that data to help come up with unique phenotypic descriptions of patients, both for prognosis and hopefully for targets for treatment. We think that the integration of the above data with genetic GWAS data will hopefully provide important genomic phenotyping, and the longitudinal follow-up of these patients should enhance our knowledge of COPD diagnosis and prognosis. I think one of the major reasons that we're interested in this is to see if we can define COPD differently in terms of its comprehensiveness, both not only in the lung but extrapulmonary, if we can define it earlier, and if we can select patient groups that can have targeted therapy so we can look at patients that can get the right therapy at the right time. Thank you very much.
Thank you very much, really, Professor Criner, for your excellent lecture with a lot of data that you collected in so long period of time, but with really a lot of new information, new considerations. I think that we have time for questions. I think that a lot of open point can be discussed. Please.
Yeah.
Jerry, thank you very much for this overview. Exactly what I think you have to switch off your. Thank you very much for the comprehensive overview, exactly what we wanted, and we have plenty of time for questions, and I will start from a very naive question. What were the entry criteria for the study? And second, when you say gold U, the class U, were clinical diagnosis of COPD and lung function that presented a ratio normal and reduced volume. In that case, did you look at the lower limit of normal? Did you explore the issue of over or under diagnosis age and so on?
Two very good questions. So the criteria for entry were broad. You had to smoke more than 10 pack years by clinical history. You had to be more than 40 years of age, and you had to be African American or Caucasian. And that was self-reported. But we excluded Hispanics for the reason is that there's about 35% racial admixture in Hispanics. So that's why they were not enrolled in the study. So it was really three things. It was based on smoking history. It was based on your self-reported race. It was based on age. Anybody else? No symptoms at all to come in. So it was a very broad population. So it's really not a COPD study per se. It's a study of smoke exposure more than anything else. For the gold U, which we were somewhat criticized for using gold term at all, which they were correct because it's non-classifiable by gold. That's a better term, and that's the term we're using in the future. Those patients also had no symptoms. We looked at the lower limit, and it didn't really change that classification at all in that group. So that remains the same. And they probably are a group of individuals who are more likely to be overweight and have restriction based on that more than anything. Now, if that's the total answer or not, we don't know, because we did find similar physiologic changes on restriction in the group that had interstitial lung abnormalities. That wasn't more evident in that gold U group than in the rest of the gold grade, but there were some individuals in that gold U who were overweight, but some also had interstitial abnormalities, just like the group did in the patient population at large.
Comment about this point, because it's very interesting, because I think that in clinical practice we have a lot of consistent number of patients like that with some feature of COPD but without spirometric confirmation of that. If you think that imaging may be the true for diagnosis of COPD, thickness of airway wall or emphysema, this group of patients, gold U, they have these abnormalities in CT.
They have some of the symptomatology. So they don't have any complaints of cough or mucus production, but some of them you can see have exacerbations. So they have these clinical symptoms, whether that's, we call them bronchitis or acute bronchitis. You know, it's part of the spectrum of the disease, because those patients definitely have exacerbations that some of them even go to the hospital for, they're hospitalized for. And some of them end up having radiographic evidence of structural change, either airway wall thickness or emphysema. So I think, you know, there is some ambiguity on how precise we are with that definition. And there's probably some people that were describing, oh, they have bronchitis, they didn't smoke, they really have disease. Especially the thing that was the eye-opener to me. Women develop disease earlier than men, and African American get a different disease than Caucasians do.
Comments? Question?
Thank you very much for the excellent presentation. I have a couple of questions. One is related to the lung physiology or lung function examination, because I saw this impressive list of distinguished academic institutions in the United States participating in this study. But if I have well understood, in the first examination you just did only spirometry. You are going to plan to use for the next enrollment other lung function test? No, I was wondering how his in the routine examination of patient in this center use the lung volumes and diffusing capacity, because when we as ATS ERS task force for standardization of lung function measurement, we issued our document in 2005. We considered a sort of first line examination, not only spirometry, but lung volumes and diffusing capacity, at least in the tertiary center. The second question is related to the issue that today is very much emphasized, which is just not only the genomic side, but the gene-environment interaction, especially in a chronic disease like COPD. So I was wondering how, or if and how are you going to take it into account, this gene-environment interaction in the next phase of the study?
Those are all very good questions. So a little bit about the methodology of how spirometry is done and how it's quality controlled. So we use the same spirometer. We use the easy one. So all the sites have that. All of the tracings are uploaded to a central core that's read by Jim Crapo's brother, Rob Crapo at Iowa, or I think it's Iowa, Utah. He's at Utah. And they're all certified at their standard levels that are done. Then each coordinator who does the spirometry has to go through a testing phase and gets critiqued and has to pass that grade to go on. So the instruction is the same. The tool is used the same across centers. We do pre and post bronchodilator and then do the radiographic imaging 20 minutes after the post-bronchodilator administration. So there's some pairing with the spirometry, with the CT scan that's done, and then the tracings are all quality controlled for that. That being said, you're well aware of multi-center trials and the variability of doing that, it becomes an issue. But it's about as good as I think we can overall make that. In terms of lung volumes, we don't do lung volumes with this study. The lung volumes that we have to analyze are the volumetric lung volumes taken off the CAT scan. So, you know, we try our best to teach the CT technicians, but they're not done with spirometry or lung volume assessment by a physiologic tool to do that. So there's some limitations to that, but that's the lung volume that we use. We use it from the CAT scan. It's also different. It's being done supine rather than upright that we're used to, but you know, it gives you some clue. The diffusion capacity, we didn't do it in the first study, just because of what you said. It's variable, what are we going to do with it? But it was thought to be important, and we thought that we missed something. So we went back, and we thought that there was enough money that we could buy a machine for each center, teach each center coordinators how to do that, and try to do that in a standard way. Now, how good we're going to be able to do that with QC, we don't really know, but we're hopeful that we'll get some useful information on that. In terms of the gene-environment interaction, which I think is buried in a lot of this, it's buried in age, it's buried in, you know, United States, African-American, Caucasian populations, for the most part, are very different. Where they live, what they do, and what their socioeconomic status is. So there's more people who are lower socioeconomic status, it's obvious, that are in the African-American community that do more blue-collar jobs. They're more exposed to pollutants, both where they live and where they work. And I think those sort of things, we have a paper that's actually in review right now looking at the occupational influence of what happens. And there's a strong signal that regardless of your gender or your race, your job and what you're exposed to matters. And we have a more comprehensive environmental survey that we're doing in phase 2.
Thank you for your presentation. And thank you for taking the effort of doing this kind of research that that is obviously very needed. One thing, a couple of comments, if you want. The first thing about this U group, this has been described some time ago. I'm sure you remember, by Manino, in one kind of his epidemiological studies, in which he found really that there were a group of smokers that they thought they might have COPD who really had a restrictive abnormality. That's what you are describing really, it's a restrictive abnormality. And there is another paper in the New England later on, that's what they call like something like pre-fibrotic disease that I'm sure you've seen also, in which they have CT scan of smokers with COPD, in which fibrosis is one of the, at least interstitial markings. We have even published a paper on that, showing with Marina Saeta and a group of Padova and myself, that thickening with fibrosis of the interstitium and the alveolar walls is not uncommon in COPD, and I suppose that this kind of brings you back into fibrosis as also another disease related to smoking, right? So they have the same fibrosis thing. The other thing that's interesting to me is that what you have found in the CT scan, and this is interesting, that is the same thing that in the 50s and 60s the Thurlbeck and so on also found, looking at autopsy pathology, right, and showing that the main relation between pulmonary function, FEV1, and lung pathology was the emphysema. It was the emphysema, interestingly enough, because they did not look at the small airways. Unfortunately, you are not looking at the small airways either, meaning that you are looking at the small airways, but not the small airways, meaning less than 2 millimeters in diameter. And this is a problem that, even Jim Hogg kind of recognizes and so on, that with the CT scan you can get down to, if you're lucky, close to 2 millimeters or a little bit above. And maybe that explains that enormous amount of noise that you have in the very, very small airways in that graph that you saw in the stage 4 and so on. So that might be, and that might also be interesting in the sense that you were surprised that you had an increase in gas trapping by CT scan that was not related to emphysema. But it shouldn't be, especially in people with younger smokers, because it's mainly related with disease of the small airways, as you know. I mean, so it's the closure of the small airways at high lung volumes that produces the gas trapping. And then it gets worse as the emphysema comes, so, and then that's what I mean, that in the sense that, the real small airways, I don't know how much, you get into there. And I hope that Jim Hogg, I wish he would look into the pieces, well, I guess in this transplant lung, into the light microscopy to relate it to his micro CT, because then we will really know the truth about the small airways. But anyway, I'm sorry about this this kind of old physiological thinking, but it's a great effort that I hope that we'll learn a lot about it.
I totally agree with your findings. Actually, one of the pleasures I've had with this is I've worked closely with Jim over the last 3 years doing the micro CT with him, and he has a wealth of knowledge that goes back 30, 50 years, and applying it to using more later day techniques, and then being able to look and marry that with the genomic and longitudinal follow-up, I think may give us some clues to whether his hypothesis is right, that small airways disease leads to emphysema, and at what rate and what factors accelerate that progression. Thank you.
Okay. Okay. Next question.
Jerry, we had this morning within the COPD group, Nicola Sverdellati, who is a very active radiologist in the field of imaging, or lung imaging, interested in all diseases, but the focus was on COPD. And we shared a lot of concept that you actually showed here about phenotyping. And you participated in between to the clinical cases. So now I am asking the clinician, Jerry Klein. The clinician, Jerry Klein, I know the guidelines that do not recommend CT scan for phenotyping. But because of your specific experience, clinical and in the COPD gene, do you have a recommendation that, as an expert opinion, on when and who to phenotype with imaging?
It's a very good question and something that's difficult. So there's one that's a no-brainer. The patients that meet the criteria for imaging based on lung cancer nodule detection, that's going to be part of guideline care. It's some of the guideline care in the U.S. that's recognized now by payers. So that's something that's going to be done in a large group of individuals who are going to have gold graded for disease. So I think that gives the opportunity of CAT scan imaging to be done, just not looking for a nodule, but take that scan, go over it, and look at it for clinical phenotyping to a greater population than ever was before. So I think that's useful.
Thank you very much, Professor Criner. Very nice presentation.